Everyone, we're so glad that you're joining us. We're so appreciative of the opportunity to share time this evening, even though it's in virtual space still, working our way back downtown. But we are so glad that you joined us this evening. I'm Dr. Jocelyn Evans. I'm the Associate Dean of the College of Arts, Social Sciences and Humanities at the University of West Florida. And tonight we have a panel entitled, How Does the Pandemic End? And What Have We Learned? Perspectives on COVID-19 and Beyond. And our plan for this evening is to facilitate a robust dialogue among our select expert faculty at UWF across multiple colleges to talk about where we've been and where we are right now and where it might be that we're going. The partnership tonight, particularly, is across the departments of Anthropology, Communication, and Public Health. So I'm going to tell you a little bit about who we have sharing with us this evening. Dr. Meredith Marten is the Assistant Professor of Anthropology. She teaches cultural anthropology, medical anthropology, and African studies. She received a bachelor's degree from Florida State, a master's in public health, international and development from Tulane, a doctorate in medical anthropology from the University of Florida. So she's our medical anthropologist. She's a cultural and medical anthropologist. She works on HIV prevention programs in East Africa, which led her then to her current research, which is on reproductive health and maternal mortality. Her primary research interests include equity and access to HIV and maternal health services in Tanzania and in Northwest Florida, focusing right now on volatility in aid and health policy effects. How it affects the health and well-being of women living in poverty. So that's Dr. Marten. Then we'll hear from Dr. Justice Mbizo. He is an associate professor, teaches epidemiological research methods and applied public health analysis. He received his bachelor's degree in healthcare admin from Concordia in Michigan, his master's in health services administration from Central Michigan, and a doctorate in public health from Morgan State. His research focuses on applying epidemiological and statistical methods to understanding underlying multi-level causes of health disparities in chronic diseases. These methods include the integration of emerging information technology and health disparity solutions. He's interested in the role of personal, community, and systems factors, how they contribute to the health and health-seeking behaviors of people with chronic diseases, among particularly underserved and marginalized. His work also extends to international health in HIV and gender-based violence and its public health impact. And finally, we have Dr. Athena Dupre. She is a distinguished university professor in communication. She teaches leadership, health communication, workplace dynamics, and interpersonal communication. She also directs graduate programs in strategic communication and leadership and health communication leadership. She received her bachelor's and master's degree in communication from the University of Southwestern Louisiana and a doctorate in communication from the University of Oklahoma. She has diverse experience in working in journalism, public relations, and the academy, converging in the fields of leadership and health communication. She's authored and co-authored 5 books and has several chapters and articles on various aspects of communication. So we have a fabulous panel for you this evening, and I'm just going to kick it off and ask each of our faculty experts to kind of speak from their perspective about the pandemic. So let's start with Dr. Mbizo. Justice, you're focused in your scholarship and your teaching on public health. What does a public health perspective emphasize in examining this pandemic? We can't hear you, Justice. Are you? Still muted? It may be, Brandy, that we have to make everyone a co-host. There she goes. Okay, she figured out the workaround. Okay, Justice, can we hear you now? You might have to unmute. I think you can at this point.
Oh, well, thank you so much, Dr. Evans. It's good to be engaged in this kind of discussion tonight, as well as we ought to, I think, for the most part, in order for us to be on the same page as to how we can get over this pandemic. So in terms of your question, from the public health perspective, I think we in the public health arena have actually expected something of this nature, something of this magnitude to hit us sometime very soon. About 2000, the public health community began really amplifying the message that we are about 100 years from the 1918 influenza outbreak, that we should be putting together systems and look at the infrastructure in public health, as well as, and using the phrase infrastructure to include both the services as well as the workforce capacity that we have in this country. And so one of the things that you take a look at the infrastructure is you have to look at where the money in the health budget goes to. Something that's very telling, this is data from 2019, actually just a few months before the pandemic broke out. If you follow from the left going to the right, you'll see a very small percent of about 3% of health dollars out of $3.8 trillion going to public health. It says public health activities. That includes things such as looking at community resilience, preparedness for response to all kinds of emergencies that can affect health, impact our community in terms of economic disruption, educational disruptions, as well as causing the overwhelming flock of sick people to the healthcare systems, which, by the way, the healthcare system is actually a subset of the public health system, just to clarify something. And so that's where we are in public health. That's what we in this arena spend our times in working with our students to get to understand how we can move forward.
Thank you. So as I connect the dots, what I hear you saying is, in terms of money spent on healthcare, what would go towards pandemic would fall in at public health services, which is 3% of what we spend on healthcare. So that's pretty striking. Brandy, you were putting up the next graphic. Dr. Mbizo?
Yes. Actually, just to follow up on that, it's very interesting that in the United States, we actually spend of the health budget as a whole, 10% of the health budget actually goes to public health. The 90% goes to treat people who are sick. And when we begin to dig in and understand why, we look at different studies that have been done nationally. The most robust study was done about 2015 by the Rand Institute, or Corporation rather, in California, to look at what we call disease diets. How many chronic disease do Americans have? We have a huge population of people in this country who have multiple chronic diseases. In fact, the number is actually 60%. So when you have a large population like that, that requires so many treatments, it means we are moving from the left side of this continuum from primary prevention, going past the secondary prevention stage, and now we're getting to tertiary prevention. Now, when we start thinking about tertiary prevention, we have to think about the local health system capacity. I probably could venture and say that a great deal of majority of our people in community now understand some very small number that most people didn't pay attention to, which is the number of ICU beds in your local health system. 111 is what we have here locally. And then when you have a big event, such a catastrophic event as COVID-19 pandemic, and you have more than 111 people who need ICU beds, then you got a brouhaha on your hands, right? And that's what we find ourselves in. So the nation and the world really got caught with its pants down, right? We understood what could potentially happen, but I think the people that were speaking and trying to make those who can make decisions and allocate resources for things to happen in order to be prepared, they weren't really probably either one, communicating well, or those to whom the message was being communicated to did not have either the capacity to understand what was being communicated and what the danger was, because this pandemic is not going to be the last one. We're going to have other events that are going to be just as disruptive, and how prepared we are, it's all up to us as a society.
That's terrifying. I don't think that's what I wanted to hear, that the future looks like more pandemics. but that makes a whole lot of sense. Seeing the phases is really helpful, Justice. So Meredith, you're not in public health from the same vantage point, but you very much are focused on public health, but from a medical anthropologist vantage point. Can you tell us what kind of perspective does your discipline bring to the study of COVID?
Sure. Can you hear me okay?
Yes.
Great. So yeah, I'm an anthropologist, which a lot of people don't really know what that means. And it's kind of an obnoxious goal that we have in anthropology. We seek to comprehend the entirety of the human experience. So we have extremely lofty goals in our discipline. But there are a couple reasons why an anthropological perspective in particular helps us better understand pandemics, because one of the central pillars of our discipline is to understand social phenomena from a holistic perspective. And this includes a couple different axes. On the one hand, we want to understand holism across space and time. So this is why archaeology, for example, is part of our discipline, is we're trying to understand human experience among those who lived long ago. And we also apply a cross-cultural analysis, so studying differences and similarities across populations across time. And holistic in another sense, in the sense that we try to understand how, all different kinds of experiences and sort of dimensions of experience intersect and are contingent. And so we understand in anthropology that politics and economics and gender and history and trust and pride and love and fear, all of these things intersect. And so I think we can understand this in an intuitive sense in our own experience of the pandemic. Like we all know, how gender and economic class and race and, being a parent, being a student, living in a particular place, living in urban environments, rural environments, that there are all these different dimensions that impact on our experience of a pandemic or any social phenomena. And then sort of extending on that, we also focus on complex systems. So the sense of holism and all these intersecting components in our own lives, but also understanding how all these intersecting pieces, like social forces, large scale ones, like global political economy and global health policy and ecological trends, etc. All of these pieces intersect at a global level as well. And so we try to understand phenomena like this in a multi-scalar dimension. And so that's the perspective that anthropologists approach things with. And within that, I'm a medical anthropologist, so I use as sort of my entry point things like pandemics, and really looking at it from a intersecting social, structural, cultural angle, and how all those things can impact on one's experience and well-being and health. So that's where I'm coming from in this.
So Meredith, we have pulled up the graphics that you shared with us.
Yeah.
For you, what do these graphs say? Why should we pay attention?
Yeah. Well, so anthropologists are very comparative in our analysis, and this probably by this point doesn't really surprise anyone that the US has done, compared to other countries, not well. We have not done well, both in terms of total death count. So on this slide, 703,000 people as of a couple days ago. On the other slide has deaths per capita per 100,000. And so that's probably a better way to understand, based on demographics, just the impact COVID has had on the US population. So to be clear, this is among the 20 countries most affected by COVID. And we're fourth on the list with a really high rate of death per capita. And what's interesting about this too, and Justice can probably speak to this in a little bit, a few years ago, there was, a pandemic preparedness ranking or something, which countries are best situated to successfully manage a pandemic. And the US was predicted to be number one, was followed by the UK, based on things like, the wealth and the technological capacity and things like that. And so seeing what previous rankings were and what, the pandemic certainly isn't over yet, but how it has emerged in the United States, it's really striking how much work we have to do for what Justice was just describing. How do we get through the rest of this and for the next pandemic that's inevitably coming? And so that's what those slides mean to me. Others, I'm sure, can weigh in if they want.
Those are really powerful. There has been a question, and I think it's related to exactly what we're talking about, which is the public health infrastructure that we have. We're expected to do really well. We didn't do really well. And Justice talked about the how we spend our dollars and what that means in terms of preparation. We have a question. Do you see community or business partnerships as a sustainable model to support the public health infrastructure? I don't know if we want to touch on that before then we shift to thinking from a communication vantage point.
If I may jump in and take that question. The interesting part about public health is coming out of 1918, the pandemic that happened with influenza, is a question was asked, what is public health? And one fellow by the name Charles Winslow came up with the definition and said, public health is the science of the prevention of disease through coordinated community efforts, organized community efforts. Over the years, and later on in 1988, in a publication from the Institute of Medicine, which is now the Academies of Science, part of the Academies of Science, said we have to revise the definition for what is public health. And we dropped out that part that says organized community efforts. But what really public health is about, it's organized community efforts, which goes to the essence of this question. And I think we have to go back to that. If you look at the amount of federal dollars that actually come to do public health stuff to the local health improvements, it's actually far less than what the states and the local municipalities and jurisdictions provide and combine with business. So we have to go back to that framework.
Okay, Dr. Dupre. Oh, Meredith has a comment. I saw that. What do you have to share, Meredith?
Yeah, I agree. I think it takes, all hands on deck. But I do think that it's really important that there is a strong public component, that we have a public health infrastructure that's well supported. And especially I study volatility in donor aid that's notoriously fickle, and in policies, and seeing the impacts that has on populations who are depending on healthcare. Uncertainty is a component of that, and controlling for the volatility in healthcare provision, I think, is hugely important. And I also think it's important that we keep health equity at the focus of everything we do, and having a strong, accountable system of public health at the center is important. To ensure that we have a more equitable health system now and in the future.
Okay, Dr. Dupre, you study health communication. So how would you be in a discussion with community members, with your students, about what communication studies has to share concerning pandemic?
Thank you. It's an excellent question. Health communication, it sounds rather self-explanatory, but it really includes a lot. It is basically the way that we seek information, the way that we receive and process information, the way that we share information. And so in a health environment, that goes from everything from macro. So we are not public health, but we partner with public health a great deal. So health campaigns, health awareness, health information programs very often have a communication element. And a lot of what we study is how can we create those messages in such a way that they are received by people, understood by people. We're very big throughout our discipline in saying that listening is probably the most important communication activity we engage in, and that two-way communication is far more powerful than one-way communication. So whereas I think a lot of people think, oh, a health campaign, you're just giving us information. From a communication standpoint, we're very often starting with going into those communities and listening to people's concerns and building those relationships and learning from that what it is that people want to know. Who do they trust as sources of that information? In what ways do they get information? So there's sort of that macro level. So as you might imagine, as health communication scholars throughout all of this, because we also write and study crisis communication and things like that, we have been watching so many press conferences and just saying, what are they going to say and how are people going to respond? And all of the sort of rules that we teach and know and believe about crisis communication have been obviously really, really, really put to the test. And it's been fascinating. There's sometimes when I kind of wanted to cheer, and other times when we've just cringed and thought, oh, this is not what the textbooks say. This is not the ideal situation. So on one level, we are really looking at those macro level situations. In this case, how to communicate worldwide, literally, about an issue that is emerging. And so, we talk about, provide consistent information, but very hard to do that when the information itself is not fully known from the beginning, and when the recommendations change as things happen. So some of those rules about have one voice, well, clearly that is not going to happen in today's communication environment. There are many, many voices from the authorities, from politicians, from community members, from your mother-in-law, from your everybody that you know, for everything on social media. And so managing that communication rich, but also sometimes a communication very perplexing and contradictory environment. So we're very interested in that. But it goes everything from communicating about health in health situations. So I often say, I am not a clinician. I did not go to medical school, nursing school, anything like that. But I've spent a great deal of my career partnering with people who did. And my role is helping them take the immense knowledge that they have and learn how to convey that, how to listen, how to ask questions, how to partner with people in making decisions. So during this pandemic, we've been really interested in how is it that people at that level are making decisions? How are they making decisions about things like masks and like vaccines? And it turns out to be a really fascinating, complex. I mean, humans are funny creatures. I know that's really groundbreaking. You heard it here. But one of the things that we do, of course, is we create words to help us express the things that we are experiencing. And it's been interesting from a language and communication perspective to see all of these are just a few of the terms that we really didn't use on a regular basis or didn't even exist 2 years ago. So it's hard to believe now that COVID-19 was unknown to us not that long ago. And some of the others that have emerged in popular spread, I mean, who was talking about super spreaders? We definitely weren't talking about Delta variant. Flattening the curve, perhaps people were in some venues. Public health, flattening the curve makes really sense. For the everyday person, that wasn't so much that they talked about. You know, some comical ones like COVIDiot, Blur's Day, which was created to sort of acknowledge that when we were all working at home and doing that, we didn't know what day it was. It was all a blur. You know, quarantine was a phrase coined to talk about high school students homeschooling from home. Quarantini, a way to cope for some people. Maskne, you know, things that happen to people's complexion when suddenly they're wearing masks. Social distancing, we didn't talk about that 2 years ago. So I've been spending a lot of time talking to people, mostly just asking questions and listening. You know, what sense are you making of this? What decisions are you making? In a non-judgmental way, tell me why you're making that decision. And really trying to understand the way that people are managing information, understanding information, acting upon it, and what are they telling each other? Because sometimes we like to think we're the authorities, we tell everybody what to believe, but really it comes down to very often what do the people in our immediate environment do with that information, and we're very much influenced by that as well.
So I'm going to jump to one of the questions that was provided to us in advance, because it's right exactly about what you're suggesting, and it has to do with the information that's coming into us. You know, someone before this session said, how do I talk to members of my own family about pandemic? And a related question that's just come in, how do we, if we have such a strong public health system that can be trusted to provide truthful messages that resonate with citizens, how do we sort through the noise to get at that truth? And so I know that that's really of critical importance to you, Athena. So do you want to speak to that?
Certainly. First of all, those are two excellent questions. They are really, really great. And this idea of how to talk to people about something that is absolutely a very emotional issue. And sometimes it is family members or friends or coworkers. And I think one of the things that's ramped up the emotions, obviously, is that it isn't just a personal decision, but it's a decision that affects the people around you very profoundly. And so I can think of a few instances, at least, you know, in my experience, in which the stakes have felt so high for trying to understand or convince somebody else in their health-related behavior. You know, one of the one of the maxims, and this will be very familiar too to Dr. Mbizo and Dr. Marten, is these health models that try to describe how we make decisions. So, the health belief model says that if we're aware of a situation, we feel personally vulnerable to it, we are aware of something that may protect us from that, and we think it would work, we're going to do it. Now, if you follow that, and if you're listening to sort of the establishment, then you're thinking it's a no-brainer. You're wearing a mask, you're distancing, you're vaccinating yourself, everything. I mean, it's a no-brainer. But what also figures in is that we're not always as rational as we think. And we always think we're being rational, and the people who are not doing the same thing we're doing are being irrational. And so that sometimes is a real impediment to conversation. So one of the techniques that I've been using, and I've been talking to family members and friends and just groups of people, is doing more listening. There's a technique that we teach health providers, but I swear you can use it in every single context, and it's called motivational interviewing. And motivational interviewing is the idea that you're not trying to convince somebody, you're not trying to tell them anything, you're just asking questions. And those questions help them explore the pros and cons, help them explore the ambivalence. So I've been talking to people lately who would not like to be vaccinated, and just saying, tell me why, and what do you see as the pros and the cons, and kind of letting them talk through it. And I've been learning some really interesting things, back to the idea that humans are kind of funny creatures, that some people who I talked to months ago who said, I'm absolutely against vaccines, when I talked to more recently said, oh yeah, I just got vaccinated. And I said, well, what changed for you? And they said things like, well, my mother-in-law told me that, if I got a vaccine, it's going to increase my risk for heart attacks, and my uncle had a heart attack, and I felt I was vulnerable and I couldn't do it. But then at work, they said, if I'm not vaccinated and I get COVID, I have to take vacation time for that. That's not sick leave. Or somebody said, I go to a university, and by the way, this wasn't UWF, and they said, if I'm not vaccinated and I get COVID, that's not an excused absence. So those people who felt strongly against it kind of did a cost-benefit analysis and said, okay, I'll do it. And so people are funny and we're all this way. I'm not pointing fingers because, cost-benefit can shift on a dime, and we don't always know what it is. So one of the things we've learned, and we knew before, but we're seeing it, is that in many cases, telling somebody what to do is not very effective, but helping them work through what are the pros and the cons, and maybe think through it themselves and not feel that they're being judged or attacked is sometimes, ironically, a much better way for them to make choices differently without us telling them to.
That's really good. That's good. So I'm going to back out.
Can I jump on that for a second?
Oh, yes, Meredith, you can.
I think that's so wonderful to hear, Athena, especially in from this cross-cultural analysis of something like vaccine hesitancy, for example. The emphasis on listening is so important, and from a global health perspective, we've learned sort of time and time again that telling people what to do is oftentimes, especially in cross-cultural contexts, can work against you. And a lot of times trying to understand the roots of hesitancy or the roots of mistrust can oftentimes be really complicated and rooted in stuff that is, if you think about the complex interactions of things, can make complete sense, can seem totally rational. And so I think the question about trust, I'm assuming we'll talk about that more, but there are really important dimensions to how to trying to think about how to create trust, and especially related to vaccine deployment.
Well, so that kind of is going in the direction that my question, I was going to get us to talk a little bit about how, if we were expected to do so well, if we faced a pandemic, we're expected to be number one, but then we did very poorly. And I think that has fed into the trust issue. And so I didn't know if the panelists wanted to address, what went wrong? Why did we perform so poorly? And then how does that make it difficult moving forward, communicating effectively with the citizenry about pandemic?
Just let me jump in. I think the question about if the public health system is the best. Well, actually, the next slide that I have for you may dispel that myth, like, because the public health system in the US is, we are actually so, probably for lack of a better phrase, well, actually not a lack of a better phrase, that's actually a good characterization. We are absolutely drunk with healthcare. We have an insatiable appetite for healthcare, for going to the hospital, right? I'm sure you have heard stories of people who had a headache, they wanted to go to the ER, but it's just a headache, it goes away, okay? Public health system in the US is suffering because we don't, if you look at the next slide I have, look at the number of people that are in the public health workforce. These are federal, state, local county people who are interviewed every 3 years. They conduct this thing called the Public Health Workforce Interest and Needs Survey. This is one of the variables, which is what is the educational level of these folks? And this also speaks in part to the question of how do you package the messages? And Dr. Dupree, I've actually shook my head many times when I hear people who are supposed to be public health officials standing and they give a news conference or talk about some situation, an outbreak or whatever. And I'm like, what the world is this human being talking about? But if you look at the right corner, 14% of the people that are working in public health actually have formal public health training. So it's no surprise we pretty much can fumble anything with all the resources the United States has. And there is always a perception when people are outside the US to think that everything is perfecto. But these are the challenges. We don't have the workforce, the trained workforce who knows these things. And by the way, Dr. Dupree, and based on our previous conversations before, we need in public health communication specialists, because even for the local health department director giving that news conference, they have to know how do they communicate with the people, the citizen, so that we get the kind of response that we need to have in order to mitigate the impact of whatever disaster event we're dealing with, including a pandemic.
So I want to talk about interventions because we've focused on public interventions across the country. Some of them have been kind of state by state. You know, there's been some dramatic differences across states based on political control, various factors. How is the shape of intervention and the effectiveness of intervention efforts, how is that a result of cultural context? I know some of you may want to answer that question looking specifically at America, and some of you may want to look at other countries around the world to illustrate. But what is the impact of cultural context on the effectiveness of intervention efforts?
I can pick up that a little bit. There's definitely a lot wrapped up in that question. I think sort of bridging Justice's comment, Dr. Mbizo's comment, I think part of the reason I'm assuming that public health is persistently underfunded is that if it's working really well, it's invisible to us. If a pandemic isn't happening, yay, public health, right? And a lot of infrastructure and a lot of work goes into the prevention of epidemics and pandemics. And I think culturally, certainly in the US, but elsewhere too, there's a really biomedical and technological focus. We really love tech and have a sense that, you know, technology will save us from everything, from climate change, from pandemics, that you know, someone will invent something genius and it will save us. And so that can oftentimes, I think, make it seem as though something that's low tech or no tech, like social physical distancing, isn't very effective, or a mask is, flimsy. I can't imagine this would, protect me. When they do, masks are really quite effective. And to Dr. Dupree's point earlier about the importance of neighbors and community members communicating with each other about their experiences and their concerns and how they make decisions about their own healthcare. A lot of that, I really loved how you focused on the two-way communication is so important, that a lot of what I think really needs to happen now and in the future is to have a much more robust community response that engages community health workers. This has worked beautifully all over the world in a lot of different cases, and in many times this includes people who don't have a medical degree and can't necessarily give out vaccinations, but they can give advice and they can chit chat and help someone reach a decision, and convey empathy and understanding, and importantly can understand the local context, and potentially the familial context as well, that goes into making these complex decisions. And so culture is really kind of a black box term. It's kind of vague, but just in general, culture is anything that's learned and shared. And so everything from decision-making processes to, what does a mask symbolize, to, the decisions that go into making health policy, those are all cultural in the learned and shared sense. And so there are multiple ways in which culture intersects with these processes.
Athena, jump in there.
And I'll be really brief because we've got a lot of other really great questions. But just one of the ways that I've gotten at that, and I love the way that she put that, is one of the things that I've been asking people a lot is, who do you trust? And I think that comes back to a lot of cultural assumptions and personal experiences. And it also comes back to the other question of, how do people sort through all of the information? Well, in some ways we do sort through it, and maybe not in the best ways. But I've found, of course, that that question of who do you trust comes back. And so we often forget that science kind of is a culture, and a faith in science is a culture of its own. And so some people hear Dr. Fauci and say, well, here's the authority. That's who I trust. Other people, and sadly, there are some historic reasons for some members and some populations to not trust the medical establishment. Not any particular person now, but historic factors have said, I don't know if they have my best interests. So maybe I trust somebody else. Maybe I don't trust the person at the press conference, but I do. As Dr. Marten pointed out, I trust the person I know in my community. And that has made this incredibly complex. But who do you trust, I find often is a very revealing question to ask.
So someone has mentioned that once we were in full-blown pandemic, stories began to emerge about the Spanish flu from 100 years ago. And so given what you study, given your vantage points, how did you react to this becoming the hot subject, Spanish flu?
Well, I think I read somewhere, correct me if I'm wrong, please, but that we still annually spin-off variants of the 1918 flu comprise the seasonal flu. And so if we want, I think the title of our panel maybe oversold a little bit. That, if the 1918 flu is a guide, we're going to be dealing with spin-offs, despite having a fabulous, super effective vaccine created in record time. That it's it can signal to us, this is something that we'll be managing potentially forever. Although, I mean, vaccine technology is really impressive. Like the ability for something to be cooked up that I think I read somewhere that there's something that's, targeting the spike protein particularly. And so any virus with a spike could be attacked. So, who knows? But gosh, it's really interesting to see, the old pictures of people wearing masks in 1918. It's just these images are really striking, and it's interesting to hear, more than 100 years ago, we were dealing with the same stuff, like many of the same issues. And this is pre-vaccine, pre-antibiotics, even like medical technology has grown enormously, and the technology we have now, rooted in really impressive science, we still have so much to do on the social science. Obviously, I'm biased as a social scientist. We still have so much to do on that front to address these larger concerns that are still something that we grapple with hugely. And so I think back to that slide that Brandy showed earlier about the U.S. being ranked as highest in preparedness and performing way underperforming compared to expectations, also needs to be understood in the context of we're among the first to massively roll out vaccines. And so despite the tech, we still are performing underperforming compared with a lot of countries who don't have that access yet.
So I think the issue of the cultural aspect, one, I think what Dr. Dupree alluded to is the historical context. For example, the landmark case of 1942 to 1972, down the road here on I-85 in Macon County, Alabama, the Tuskegee study, right? That caused a lot of distrust, and it has a long-lasting effect on particularly descendants of former slaves, African-American communities, and in terms of participating and availing themselves to the uptake of any new therapeutic that come out quickly. Now, some of the things that have to be understood, I think, explain, and that falls on the public health folks, is to explain in very lay terms how, for example, the COVID-19 vaccine didn't come out in 11 months, right? The National Institutes of Health, the federal government, the National Science Foundation, NSF, they fund basic research that's always ongoing at universities, almost some like ours. I know a few people here at UWF who do basic research in the labs. But those basic research activities are intended to create templates so that, and when they do that, they're basically anticipating what could. They're scientists thinking about what could happen, and what if that happened, what do we do? We create these things and we'll put them on the shelf and put them away. But when an event comes up, we're like, oh, wait, remember what Dr. Evans developed? Maybe let's take a look at that too. Then we activate that. That's the kind of preparedness, always anticipating, understanding that microbes always adapt. Microbes will change. They go through genetic shift, genetic drifts. There's some stuff that you go take microbiology with Dr. Lippert in biology. He'll explain a little bit in depth. But those are critical, fundamental scientific basis of public health that we need to understand and be able to articulate to people so that they know these things were not just cooked up overnight, right? These vaccines are effective. They reduce hospitalization rates, very high percentage, 90-something percent, 92 in some study that I saw from University of Minnesota. They reduce significantly. Without vaccines, can you imagine where we would be? Last year, about this time, the numbers of daily mortality numbers were quite scary. Everybody was getting depressed. But with the tool that we have, the vaccine, and then we have the other mechanisms or strategies like social distancing. It's not going to be one tool. It's going to be a tapestry of multiple tools that we deploy. But at the central, the core of it will have to be vaccines, because That's what is going to prevent the right.
So something's been coming up in the chat, and we've kind of tiptoed around it, but we haven't addressed it head on, and that is, you know, what is the role of individualism versus collectivism in what we see in terms of intervention implementation? Athena's like, me.
No, and thank you for those comments in the chat. And John, I think you expressed it very, very well. Yes, I mean, very much. And this idea that, you know, by many people's estimation of it, the United States is the most individualistic culture on the planet. We tend to think in terms of, you know, agency of one and personal freedoms and things like that. I've been, for years, I was very lucky through UWF to spend most of a summer in Japan a number of years ago studying their health system. And since then, I've been doing this little mini lecture about why the Japanese live way longer than we do and why they will survive a pandemic better. And I didn't expect to experience that. But, you know, the things that, of course, I mean, they would always wear a mask. If you just sort of wake up feeling not like maybe you're coming down with something, you would wear a mask. And I think it is a much more collectivistic culture for the good of the group. You would do that, and they've always done that. Oh, sorry, now there's the dog. And he finds squeaky toys that I didn't know existed. And other things that they do that are really interesting too is they don't shake hands. And so for years now I've been saying shaking hands is a really risky thing if things get out of hand. They would never, ever, ever in a million years put food in their mouth before they washed their hands. And we're really accustomed to, you know, going to a cocktail party and having a buffet and shaking hands and eating. That would just be completely taboo for them, for very good reason, by the way. So maybe we're going to become a little bit more like them. But I think also part of that collectivism is that a willingness to more or less follow rules and not as much inclination as to say I'm going to resist recommendations because that is my personal right. And I think that has been a big factor as well. All right, I'm shutting up.
Yeah,
Justin, I think that is something that's very critical to keep in mind, because Americans love their First Amendment right. It's my right to take it or not take it, right? So there are case studies in healthcare law and healthcare administration law that are quite fascinating with this very tenet of American culture that's rooted in the belief of that right, those rights guaranteed under the Constitution. And you have to think about that and respect that, right? And then you go back and you, in very empathetic ways, listen to what the person is saying without being judgmental about why they don't want to get the vaccine. Because once you become confrontational or judgmental, you basically lose. You have lost already. Whatever program you're advocating for, you have lost that person. And they will influence those within their circle. And from one person, it's 5, and then becomes quadruple.
I also think this is, I think, really an interesting dynamic and something that a lot of us have been thinking about, especially as the vaccine mandates roll out. I think I agree with all of that. We're certainly very individualistic, and in the US, our health system is super fragmented, like John mentions. That puts extra hardship on the healthcare system because, you know, every single jurisdiction or county health department has to manage all of this work. There isn't a more centralized system that can logistically manage. But another important thing to consider too is not only individualism, but the material resource availability and, you know, basic social safety nets, like, you know, having affordable healthcare, having accessible healthcare, having, you know, the ability to take off a couple days of work if you're concerned about the what am I trying to say? Symptoms of getting your vaccination, finding childcare. There are a number of material resource needs that are oftentimes really underfunded, not provided, not thought about. Someone I remember at the beginning of the pandemic got COVID, and their doctor said, okay, quarantine in your guest room and only use your guest bathroom. And thinking about the context in which people live, and how many people are in a household, all of these sorts of things, like these are important considerations, cultural considerations, but we also really need to not keep our eye off the really dire importance of material resource needs and how it's not adequately provided. And John Jensen's comment about how these systems were stronger 100 years ago, I think is really important, and how there was another question earlier about how to not bring in the political noise. Pandemics are completely political. There's nothing apolitical about this process in the terms of ordering populations. But so thinking politically and thinking from a health equity stance, how do we make sure that those who are most vulnerable to disease of any type, chronic disease, infectious disease, are able to access the care that they need and protected with the important systems in place that can prevent them from getting sick in the first place. And so this is, it's multi-scalar, multi-dimensional, but all of these things need to be considered in the process of overcoming a pandemic and encountering the next one.
So you used a phrase, ordering populations, and I hadn't really heard that before.
Oh,
but you're absolutely, I mean, I study political science, and when we talk about politics of public policy, it's who gets what, when, where, why, how. And that's, I mean, we could tell each other who got vaccine first and how it was rolled out and who has yet to be given access to vaccines, much less around the world who has access and who doesn't. So that's a helpful phrase, I think, for thinking about this. Jennifer Melcher mentioned something over here that I think is an interesting extension of the individualism versus collectivism kind of worldviews, and that is all of this available data. With people accessing WebMD to figure out what they have before they ever go to the doctor, that was what it used to look like. But now it's, where do you get your data from? And so I'm interested to hear your thoughts as a panel on the super accessibility in some ways of data and the lack of availability in other ways, and how that's kind of complicated our experience with pandemic.
That's an awesome question. Anyone want to jump on that one?
You going for it, or I go for it? Okay. So that's a very interesting question, and I think it goes to the whole dilemma that we all found ourselves in. I recall at the first week, and the president, Dr. Sanders, said, and the upper administration had assembled a group of a bunch of faculty from throughout the university in Building 79, and there was somebody from the P&J and wanted to ask me a question about what should we be doing. So there's a principle that I always use. In emergencies of this nature, only the designated public officer for that jurisdiction speaks on what actions are to be taken. Not too many voices speaking out of turn, saying things that are wrong, right? So I never spoke to anyone asked me about that. I'm like, no, go talk to the local health department director. He's the medical officer, the chief health officer in this jurisdiction. And he will talk to people at the university, the administration, and give them the advice that's appropriate. And it was an evolving situation that nobody knew about, right? And so those are the complex things. Now, like Dr. Dupree alluded to, everybody and their mother-in-law is an expert on COVID-19 and on quarantine and what social distance and one-on-one contact means. None of them got a clue. So, and then it goes to the data. Everybody tries to get their data here, and you can't even make sense of what it is. I have stopped looking at what they say the effectiveness of what this vaccine is, that one is, because as we're beginning to, the companies are releasing more data, you realize the data, the effectiveness is waning. Something came out today about Pfizer. Pfizer, they say it's waning. So how do you I can't send a person to say, oh, go to WebMD, go to this portal, Medscape, because by the time they get there, things have changed. So I always say, look either at the Centers for Disease Control, that's the CDC, that's the leading authority that everybody, even around the world, whenever there is an outbreak, they send to the State Department, actually they send to the World Health Organization. The World Health Organization contacts the US government through the Department of State. The State Department then goes to the White House calls the Cabinet Secretary, calls the director of CDC. There is a protocol on how that stuff goes. And so they collate these data and try to make sense. Now, is that perfect? No, by no means. But it's as close to what the officials, the government officials have, that we can go and say, this data perhaps up to the time that it was provided and put out for public consumption was the most accurate thing we got. So I try to go to those resources, and I'll look at CDC, World Health Organization, I'll look at the Florida Department of Health, then you look at the county. You can disagree with how things are done, but look at those. Those are the authoritative source for data and information for you.
Yes, Athena.
I mean, just really quickly, one of the sad paradoxes that we deal with, and I know all of us deal with it in communication, we talk about the information haves and the information have-nots. And, you know, sadly, the pattern is that the people most in need of information are the least likely to get it, and maybe the least likely to understand it from the source. So some of us who have the benefit of great education are going to the science, and we're reading the articles, and we're reading, you know, the World Health Organization and the CDC, which are actually not as hard to read as many people might think. Go to the CDC website, it's pretty readable actually. But do they have the confidence to do that? Do they have the technology to get to that? And so then it's this sad pattern that I think the gap increases, and the people that we turn to for information when we need it most are very often the least reliable sources.
You know, I'm remembering that one of the comments we received before we started was, when can I feel safe about going to social gatherings again? And so I know that we don't have medical doctors with us, but you guys know the strong resources that we can trust. What would you tell people who are looking at our current rate of spread, hospitalization rate, ICU beds, and trying to figure out, when can I act like normal again? What would you say?
I saw something, Justice is probably better suited to answer this than I am, but I saw something pre-vaccine that was really useful, just as like a quick go-to mental guide for how to figure out how to do social gatherings again. And it was along 3 different dimensions. One was outside or inside. One was mask or no mask. And another was physical distance or not. And you need 2 out of 3 of those things. And so if you're outside, then you can be unmasked if you can maintain distance. If you're inside, then masks and distance. If you can't be distance, then you need to be, what was the last one? Outside and mask, maybe that was it. I'm candidly still a little bit confused about vaccines. I'm fully vaccinated, but I have 2 unvaccinated toddlers at home. And so they go to daycare, and daycare is a germ factory. And so it's this, for me personally, as a parent of unvaccinated kids, the cognitive tax, the daily mental math of trying to figure out, where can we go, what can we do. We have pretty much stayed home unless we can go hang out with people outside. And so for the most part, I feel comfortable hanging out outside with kids, with other folks who, if we can maintain distance, unmasked outside.
So let's talk about that for just a second. And just as I see you, and you're going to have an answer to this question, when can we be normal again? But I do want to put a pin in at least the toll of pandemic long term, because another comment that we received had to do with teens who, missed their graduation and who have had to quarantine, right? And so what can we expect in terms of long-term effects that may not be directly related to the virus itself, but that will be socially with us for some time to come?
Yeah, there was a one statistic that was absolutely flooring to see, and then I'll stop talking. That it was last year, I think, 2020. 25.5% of 18 to 24-year-olds had suicidal thoughts in the last 30 days, which is massive and really frightening. And I think we all know in our own experiences that living through a pandemic is not just dodging a virus, or if we get sick, managing our healthcare, but there are cascading health concerns and consequences, and mental health looms very large. And I think the post-pandemic, a lot of these things, like culturally speaking, they're rites of passage. Graduation is a rite of passage. So yeah, that's something that I think really needs to be considered. And I also, I see the rounds of blame that circulate periodically toward particular populations for, not behaving correctly, let's put that in quotes, can be, it's important on the one hand in a social responsibility sense, but it's also important that we consider the experience of health in a more holistic sense, and that it's not just an infectious disease, that the mental health consequences and disparities too, how it's experienced differently among different populations, is really important.
Yeah, so I think in terms of the first question on when can we expect to be back normal, I don't know who has a definition of what the new normal is going to be, right? Because a lot of things have changed quite significantly for pretty much everybody. I go out to some groups, but I've always kind of, I'm fully vaccinated. And I like to encourage all my friends that the people that I tend to go to the groups with are going to most likely be people who are vaccinated. It's probably unlikely that we will hang out if you're not vaccinated, because we all have a responsibility for what I call all of us, right? It's one word, all of us. It's a concept from the National Institutes of Health, but it really speaks to the idea that we are all, even though I hate the phrase, in this together, right? Now, we're not all in this together. There are disparities in here. But I only go with people that are vaccinated. And I only encourage people to really, if you really, really want to go out, you want to participate in these things, well, here is your opportunity. Get vaccinated. The vaccine is free to you. Somebody else will cover the cost. The government will cover the cost for you, but the vaccine is available. Get it. It's safe, it's effective. So I'll do that. Now, with the mental health for children, that's a very, very troubling statistic that came out. And I think everybody, every parent, every leader who doesn't pay attention to that particular statistic within this demographic is really not thinking about the future. because we're definitely going to have a generation of people that have these mental health problems that can be triggered by other traumatic events later on in life that can lead to loss of productivity. We also may have to have a lot of kids dropping out of school. And that has, as Dr. Marten suggests, a cascading effect on health, social well-being, and we're just going to have it's a mess. COVID is going to have a long-lasting impact on society for a while.
So I'm gonna finish this out with one question for the group. If you had to identify top lessons to take away from this experience, what would they be? What are the lessons that we as a society, we as individuals, we as a university, what should we take away?
There's so much. I think we've learned so much. I think that we know we need to do better. I think that this was a massive stress test for our health system, and we did very poorly. It exposed a lot of cracks in our system, and it can't just be pinned only on health and public health. There's, you know, the social supports are not there, and the far disproportionate morbidity and mortality among communities of color, among people who have difficulty accessing resources, among people who have difficulty accessing information, like Dr. Dupree was talking about. There are so many ways in which we can improve, and we absolutely have to, because these sorts of things, I'm sure all of us probably predict these will happen with more frequency. Maybe not this scale of pandemic, but that in order to prevent this enormously expensive, deeply disruptive, almost 2-year-long pandemic now, we need to do better. However, from my own research in HIV, another outcome is that, like on the technology front, it can be really impressive. Some really impressive scientific discoveries and inventions can be made. Like there was an antiviral that just came out last week that was, I think it's Merck's. But so, you know, a lot of antiviral technology is built off of, you know, several decades worth of HIV antiretroviral technological development. I saw today that there's infrastructure being built in Africa for vaccine production. And so the critical question is, when will Africans themselves be getting those vaccines? That's extremely important for a number of different reasons. But I'm hoping that the public health, global health infrastructure that is developed through this may help to start address issues of global health equity, which is something I'm concerned about. Yeah.
I mean, absolutely, to echo that feeling, the sense of equity. I think a lot of us in health have been saying for a long time that there is no us and them, that if anybody in our world community is suffering, we are all suffering. And I don't just mean that in a sense of humanity and empathy, although I do, but I mean that in really tangible, specific ways as well. That the loss of productivity among people who don't have health resources affects all of us, and the expense of caring for people who don't get regular care and information affects all of us. And in a sense, this was sort of a metaphoric way to underscore that idea. It doesn't have to be a communicable disease for it to affect us. In this way, it very obviously does. But I hope that we can carry that awareness with us forward and realize that the divisions are purely an illusion. We really are in this together.
Yeah, I think the key thing to take is the concept of globalization, right? A few years ago, I went to a meeting in Salt Lake City. On my way back, I got to Atlanta at about 9 p.m. I got on a flight to Pensacola. There was a lady sitting next to me, and she seemed out of place. So I struck a conversation with her. I said, you coming from where you coming? You're going to Pensacola, which was unusual, right? The flight from Atlanta goes to Pensacola, where else. And she said she was coming from Amsterdam. I said, where do you come from? She said she came from Nairobi, Kenya. And she had breakfast in Nairobi, Kenya, but she had dinner in Pensacola. Just imagine that, how pandemics now, how diseases can move from one part of the world to the next. And so I look at it as there are two things we need to do, really, at home here in the US, right? Everybody has been on a plane, and the last thing, before the plane takes us off from the gate, what does the head stewardess say? They'll tell you about if we lose cabin pressure, the mask will come down, and they say what? Secure your mask first before you assist others next to you. So we need to address, what do we do here at home? Because our capacity for global engagement, of which the US has now engaged, not just the Department of State and the Agency for International Development, but also the United States Navy, deeply engaged in global health. That tells you something. And so what we need to do is strengthen our infrastructure here, our workforce in public health. 46% of the current public health workforce is set to retire or change careers. We need to listen to that report that came from the CDC, which said, who will keep the public healthy? And I have my own answer, which I say, Argos will, right? So we, just in case most of don't realize, we have an MPH program, public health program at UWF, within the College of Health. We do just this fall, UWF launched a Bachelor of Science in Public Health. This is part of a movement in the proliferation of, or the image, I should say proliferation probably could be bad, but the emergence of public health programs in the United States. Since 2000, year 2000, there has been an increase, as you saw in the other slide, about 300% increase in programs in public health. So what we need is really to retool the public health infrastructure. We have baby boomers. We have 60% of the population that has two or more chronic, or one or more chronic diseases. That is not sustainable unless we unleash this cadre of people that are going to work at the population level, not patient level. Not that that's important, not important. It's fundamentally critical. But the population level is where we need the folks. Now, when we go overseas, we need to decolonize public health. What do I mean by decolonizing public health? A great deal of what public health teaching overseas is done is framed from the Anglo-Saxon, European models, US models. But how do we get the indigenous ideas there, make them the tools that work for those populations and make them responsible? Well, the other things we have to deal with there, I think that's where I have a question, and I'm not quite sold on the idea of vaccine equity, and also the idea that we can give the vaccines. We can provide assistance, but we also have to figure out how to get some of these countries to eliminate corruption, because I guarantee we can give them $1 billion worth of vaccines, probably 550 million of that is going to go into the pockets of the ministers. How do the population benefit? We have to figure out how to reduce that level of corruption in those places while we assist. But I think that that'll be fundamental. And that will help us, because then we can keep some of these emerging pathogens at bay. Delta came from India, right? Went around the South Africa areas, and we have Ebola. We have managed so far to, the global community has managed so far to keep a very close, tight leash around Ebola. Okay, we need to figure out how do we do that and sustain that momentum and build networks of quick response teams to fight these emerging epidemics or outbreaks.
That was a good list of lessons learned. I think that the collective insight of our faculty expert panel was just wonderful tonight. And so on behalf of the audience, I want to thank you for sharing your time and expertise. And to the audience, I want to thank you for tuning in. I've worked on the programming for this Downtown Lecture Series for many years. We partner with the Office of Equity and Diversity and the John C. Pace Symposium Series to bring quality programming that really tries to highlight the important role of the liberal arts in contemporary society. The pandemic caused us to think outside of the box in terms of how we were going to be downtown and together. This was one of the mechanisms by which we tried to do this fall. We're hoping that we will be face-to-face downtown in the spring, but we will continue to reach out to all of you with opportunities like this. If you have feedback, please don't hesitate to send it our way. We would love to receive it. And from all of us at UWF, please have a wonderful evening and a very good night. Talk to you soon.
Thank you. Good evening.